العلم ليس له حدود نتطلع إلى رؤيتكم في المؤتمر الدولي 30 لطب الأطفال.
Die Wissenschaft kennt keine Grenzen. Wir freuen uns, Sie auf dem 32. Internationalen Kinderkongress begrüßen zu dürfen.
Bilimin sınırları yok. 32. Pediatrik Kongresi'nde sizleri aramızda görmek isteriz.
La scienza non ho confini. Speriamo di vedervi al 32esimo congresso pediatrico.
La ciencia no tiene fronteras. Esperamos que puedan reunirse con nosotros en el 32º Congreso Pediátrico.
La science n'a pas de frontières. Nous sommes désireux de vous avoir parmi nos au 32e Congrès pédiatrique.
विज्ञान की कोई सीमा नहीं है. हम आपको 30वीं अंतर्राष्ट्रीय बाल चिकित्सा कांग्रेस में देखने के लिए उत्सुक हैं.
Science has no border, and we are looking forward to meeting you at the 32nd International Congress on Pediatrics.
برای دانش هیچ مرزی نیست. مشتاقانه منتظر ملاقات شما در 32مین کنگره بین‌المللی کودکان در تهران هستیم.
Ladies and gentlemen, dear professors, I would like to welcome you to the 32nd International Congress on Pediatrics in Tehran. In our session, we have three great professors that it's a great honor for us that we are with them. They want to talk about different issues on neonatology. So I think it's a very good opportunity for our neonatologists in our country that we will have them. This is, as everybody we know, this is due to COVID-19. I wish that one day this COVID-19 goes away and we keep the memory of our colleagues, what they passed away because of saving the lives. I wish that we keep their memories and everybody gets safety. I would like to introduce our first speaker, Professor Ahmet Celebi from Siyami Ersek Hospital, Istanbul, Turkey. His session is about cardiac interventions in the neonate. Dear Professor, we welcome you. Again, I would like to welcome you to our session. It's a great honor for us. You accepted our invitation. We would like to have again, after this, this doesn't be the last session of us, this will be a starting of a new session for our other meetings. Well, Professor, you're welcome and you can start. Thanks a lot.
Thank you very much. Before starting, I would like to thank organizing committee for their kind invitation. I'm happy to be a part of this meeting. Let me start my sharing my slides. Could you see?
No, not that yet.
Is it okay?
No.
Unfortunately,
No.
we don't have your...
Okay, let's see. Let me go to share and should be okay.
It's all right, yes.
Yeah.
We're all ears.
Thank you. Greetings from Istanbul. Good evening, everybody. I'm going to talk on transcatheter intervention in newborns with critical congenital heart disease. Before starting, I must say that this is a very comprehensive topics and very large topics. It is not easy to talk all about, but with starting since the introduction of the balloon atrial septostomy in 1966, transcatheter interventions have evolved and developed with balanced dilatations after 1980s and stent implantation after 1990s, and then device plug closure after starting at millennium. Currently, they have assumed pivotal role in the treatment of neonates with critical congenital heart disease. Many kinds of procedures in many kinds of lesions have been performed and also reported successful in newborn period, such as creation and enlargement of interarterial communications, relief of valvular stenosis or atresia, angioplasty or stenting of vascular structures, closure of large left to right shunts or abnormal vessels, recanalization of octopus surgical shunts. But in this short time, it is not possible to talk in regarding to all aspects of intervention in newborn period, specific indication, procedural technical details, success rates, pitfalls in this access, complication to avoid from complications, midterm and long-term outcomes compared to surgery in all aspects. But I'm gonna try my best to summarize all of them. Transcatheter intervention in the newborn as general indication criteria, hypoxemia and acidosis, if there is duct-dependent pulmonary circulation, duct-dependent systemic circulation, severe congestive heart failure, ventricular dysfunction, low cardiac output, severe ventricular hypertrophy, or mechanical ventilator dependency, for being best curative option in some lesions, palliation in substituting of surgical procedures, stabilization of the patients before surgery, and delaying surgery for optimal time, or fixing the problem encountered after cardiac surgery. What we have in the treatment of a neonate with critical congenital heart disease, surgery for a long time, transcatheter intervention as well, and recently hybrid approaches. When approaching for optimal management of a newborn with critical congenital heart disease, a pediatric heart team with multiple disciplines but single focus consists of pediatric cardiologists, neonatologists, pediatric cardiac intensivists, pediatric cardiac surgeons, and pediatric cardiac anesthesiologists. It should be discussed for every neonate individual which option is safer, more efficient, better early outcome, and superior in mean and long-term results. After deciding the transcatheter intervention, before intervention, medical management of the patient is very, very important. Metabolic acidosis, hypoglycemia, hypocalcemia, congestive heart failure, low cardiac output, closed or small duct in duct-dependent pulmonary or system circulation, respiratory distress and failure should be managed with PGA1 infusion, sometimes IV fluid replacement, sometimes sodium bicarbonate replacement, glucose and calcium replacement, inotropic agents, diuretics, etc. Enterotracheal intubation is also very useful in lessening the metabolic demand in this kind of patients. Let me emphasize on low dose usually is enough for avoiding side effects of PGA1. About 5 years ago, we published our results. We have been using PGA1 about 10% of the recommended doses, which is very useful for avoiding not only effective in especially duct-dependent pulmonary circulation, but also for avoiding side effects of prostaglandins. When we classify of cardiovascular abnormalities needing intervention in neonates, we can divide them into the 7 categories. Restrictive intraarterial communication due to insufficient intraarterial mixing, right heart obstructive lesions due to insufficient pulmonary blood flow, left heart obstructive lesion, due to insufficient systemic blood flow. Early postoperative intervention due to residual shunt, residual obstruction, sometimes systemic pulmonary shunt thrombosis, or restrictive interarterial communication after surgical correction. Vascular communication causing severe cyanosis or pulmonary hypertension in pulmonary AV malformation or pulmonary arterial sequestration. Vascular communication with significant left-right shunt rarely cause need intervention in the neonatal period. And if we will have time, we can talk about intervention in low birth weight newborns. When we start with restrictive interarterial communication, survival of certain forms of congenital heart disease depends on unrestricted interarterial communication between arteries. The presence of a non-restrictive interarterial communication may be important to enhance mixing in patients with transposition of great arteries to augment cardiac output in right side of obstructive lesions, to relieve left atrial hypertension in left side of obstructions, to offload the right side of the pulmonary vascular obstructive physiology. The procedures to enlarge and interarterial communication are balloon atrial septostomy, static balloon septoplasty, cutting balloon angioplasty, and atrial septum stenting. Balloon atrial septostomy is perhaps the oldest interventional cardiac procedure, first performed by Rashkin and Miller in 1966 in a neonate with TJ and severe oxygen desaturation. It's a simple and well-known established procedure, can be performed even at the bedside with only echo guidance. Balloon atrial septostomy relieves atrial obstruction to flow, improves intercirculatory mixing, and thereby improves patient oxygen saturation. It is not uncommon before the surgical Jeter operation performed, they are referred in hypoxic and acidotic situation to cardiac centers. As shown in this baby, 61% of oxygen saturation, lactate above the 15, and also acidosis was present in this particular patient. Currently, the treatment of simple TGA perform arterial switch, but before 2 to 3 weeks, however, some patients with restrictive interarterial communication or no PDA may be hypoxic and acidotic, as shown in the previous slide. The PFO can be enlarged by a balloon atrial septostomy. We prefer both echo and fluoral guidance in this kind of patients, using this echo restrictive on the left side and after opening the atrial septum on the right side, and the patient situation after balloon atrial septostomy. And acidosis was corrected, and lactate decreased, and saturation increased. What about the suboptimal results after balloon atrial? Mainly due to septal techniques. Usually, if the patient more than 4 weeks or mitral atresia complexes, and especially if hypoplastic left heart syndrome variants, it may be ineffective. In this situation, we prefer static balloon septoplasty, cutting balloon angioplasty, or atrial septal stenting. Static balloon septoplasty is semi-compliant or non-compliant balloons inflated across the atrial septum, and this is cutting balloon angioplasty in a hybrid approach borderline left ventricle. 8 millimeter peripheral cutting balloon was used, which is the largest one, and then non-compliant balloon inflation across the septum was created a large interarterial communication. Sometimes we need atrial septal stenting if we need permanency of the interarterial communication, especially in those patients hypoplastic left heart approach with hybrid technique. You see the echo of the atrial septal stenting before and after. There is no restriction at the atrial septum. Right heart obstructive lesions due to insufficient pulmonary blood flow can be categorized into the two classes, one without VSD, the other one associated with VSD, such as isolated valvular pulmonary stenosis, pulmonary atresia, and tachyventricular septum, and other ones tetralogy follow severe pulmonary stenosis, double outlet right ventricle, severe PS of atresia, or complex TGA, or functional single ventricle with pulmonary atresia, who is going to go to Fontan tract. How can we intervene for RVOT obstruction? You can do pulmonary balloon perforation of aortic valve with a guide wires, perforative guide wires, palliative pulmonary balloon valvuloplasty in cyanotic congenital heart disease as well. I'm going to emphasize on this because of the, if there's not good surgeon or not outcomes, we can prefer, especially in early periods, stent implantation into RVOT and PDA stenting in duct-dependent pulmonary circulation. Critical pulmonary or severe pulmonary stenosis that we can do pulmonary balloon valvuloplasty. We don't prefer to do any intervention in the neonatal period unless it is necessary, unless it is very urgent. Irrespective of the RV-PH gradient, if there is critical PS, which means duct-dependent pulmonary circulation or RV systolic dysfunction occurred, or severe PS causing significant hypoxia, we do this. It is more difficult and it may be needed different equipment, extra sickles, extra maneuvers. Fortunately, with the refinement of the technique, the success rate increases, complication rate decreases. Right ventricular systolic dysfunction in critical pulmonary stenosis appearing in the neonate is not uncommon, as you see on these movies. Sometimes it is straightforward after crossing the valve with an 0.018-inch thermo wire with an appropriate sized balloon, but sometimes pinpoint passage through the valve may be taught as atresia both on echo and also on angio, unless RVOT angiogram done just beneath the valve, as you see in this particular patient. Crossing the valve is not possible sometimes without a coronary wire, which is the smallest one. And then peridilation is necessary to advance any catheter or any balloon for balloon valvuloplasty in this situation. And sometimes fixing the wires in retrograde the femoral artery and pulling back to advance the balloon in an appropriate position. Balloon valvuloplasty is the first therapeutic choice for valvular PS in current era. Technical success achieved in almost all. But even after successful dilation, uncommonly significant hypoxemia may persist due to poor RV compliance, TV, tricuspid valve, and RV hypoplasia, or persistent significant tricuspid regurgitation. In this situation, we reinstitute again prostaglandin and waiting for 1 week, or duct stenting immediate after the balloon valvuloplasty. Usually restoration of RV function, as you see in this slide on the right side after balloon valvuloplasty, both TR and sometimes TR and also right ventricular dysfunction may persist after balloon valvuloplasty. If significant hypoxemia persists, usually we prefer duct stenting in the same region, especially in those patients with smaller tricuspid valve and pulmonary valve annulus or significant fixes of valvular stenosis or in the presence of constricted duct arteriosus. This was published from my institution about 4 years ago. We implanted about 40% of the critical pulmonary stenosis into the duct. Duct stenting immediate after pulmonary valvuloplasty, we prefer antegrade D if duct is able to cross from transvenous approach. Sometimes it is not easy, as you see in this particular patient, and at this time retrograde duct stenting was necessary in this particular patient. If after valvuloplasty, if there is a large PDA, it seems that a small right ventricular, it may ultimately needs duct stenting, but the duct was large to implant a safely implantation. And then we waited for 2 weeks, and then antegrade duct stent implanted. And second, pulmonary atresia intact ventricular septum is the most severe form of critical pulmonary septum that no blood flow through the pulmonary valve. RV and tricuspid valve hypoplasia are more common. RV-dependent coronary circulation is also commonly seen in this kind of patients, so the compression of the RV is contraindicated when present. The options are determined mainly by RV-dependent coronary circulation, the degree of tricuspid valve and right ventricular morphology, and also alveolar pulmonary annulus, if it is membranous or muscular atresia. Cardiac catheterization is usually indicated in addition to complete echo evaluation, not only for intervention, but also for deciding on the best form of the treatment. This kind of patients classified as group A, B, and C. When I summarize good RV morphology, intermediate morphology, and poor RV morphology. For good RV morphology, biventricular repair is possible. In intermediate morphology, sometimes biventricular, sometimes 1.5 ventricular, sometimes it is not easy. And also, sometimes we have to send them univentricular tract. In group C, there is no doubt about poor RV morphology. Univentricular heart is the only solution. These are the echo of the good right ventricle and poor right ventricle. On the right side of the movie, you may see the coronary sinusoid and RV-dependent coronary circulation, retrograde coronary artery flow. On angiography, good RV morphology intermediate and poor RV morphology you may see in these movies. If there's good RV morphology, conventional or earlier approach was surgical valvotomy. Currently, we do transcatheter perforation of the aortic valve since they have a chance to undergo biventricular or at least 1.5 ventricular repair. Historically, we used stiff end of a guide wire, but I haven't used laser wire. But recently, we use only CTO wires, but I have also used radio frequency guide wires for this purpose. These are the in 3 different newborns, 3 different perforation systems were used, Baylis medical radiofrequency, OSIPCA, and CTO wires. And after perforating, the procedures are similar, the systems are similar, period dilation with coronary balloons and final balloon valvuloplasty with appropriate sizes, and final angiograms after all balloon valvuloplasty. If smaller RV, smaller tricuspid valve, smaller pulmonary annulus are present, after perforation of the valve, 50% no needed additional intervention. In some neonates after such procedure, as already stated in the critical PS, hypoxia may persist. It is probably due to insufficient size of right ventricle, poor compliance of the right ventricle, persistent severe regurgitation. In this situation, we prefer, as stated in the critical PS, duct stenting in the same season, or sometimes if there's good RV morphology, we wait for 1 or 2 weeks to improve the hypoxia. In poor RV morphology, if there is severe hypoplasia or no developed well implantable portion, RV-dependent coronary circulation, we do ductal stenting since their ultimate repair will only become univentricular correction. Retrograde approach is necessary. Fortunately, they are straight, and it is straightforward procedure as seen in this particular patient. Transcatheter perforation of the pulmonary valve has been started near 20 years ago, and the prognosis of these patients significantly improved. I'm going to emphasize on cyanotic congenital heart disease with severely diminished pulmonary blood flow. Our institutional approach in this kind of patients, if there is a patent RVOT, antegrade flow, and dominant lesion is valvar, we do palliative balloon valvuloplasty in place of surgical BT shunt, because they have higher mortality in especially newborns. If patient very small infant balloon, we do RVOT stenting. If patient has no antegrade flow or duct dependent and duct is still patent, we use duct stenting. Palliative pulmonary balloon valvuloplasty is an effective procedure for relief of pulmonary valve stenosis in tetrahedral and other cyanotic congenital heart disease with pulmonary stenosis without significant morbidity or mortality. Improve oxygenization that disappear the need of surgical shunts. Natural antegrade flow, no additional volume load to the ventricles, and stimulates of the pulmonary annulus as well. This was the publication from my institution again on the evaluation of efficacy and utility of palliative pulmonary balloon in tetrahedral patients. Several slides for balloon dilatation of the RVOT in tetrahedral. All was successful and underwent to total correction at a later age. Also, we use palliative balloon valvuloplasty in those patients univentricular heart with severe pulmonary stenosis. Antegrade approach was caused to heart block, and during pacing retrograde approach was used in these patients, and also he has reached to bidirectional gland palliation after 6 months. And RVOT stent, especially in tetrahedral with diminutive RVOT and pulmonary arteries, which are not amenable for surgical correction, we place our stent into the RVOT for palliation instead of systemic pulmonary shunts. You see the very small antegrade flow and no contrast in the PA on the left side, and after stenting on the right side, well-developed pulmonary arteries and good RVOT. And again, another patient with hematuroncus, that one of the pulmonary artery from ascending aorta, the other one from right ventricular artery, very tiny passage before, and you see the RVOT stenting. In tetrahedral also, we pay more attention nowadays for preserving the valve, not covering the valve with the stent, and do balloon for the valve. And these are the multicentric study from our centers and another centers from Istanbul. And duct stent for pulmonary circulation is a reasonable, less invasive alternative to surgical systemic pulmonary shunt, not only those patients after perforation of pulmonary valve or after balloon valvuloplasty, but also in newborn with complex congenital heart disease. Since surgical shunts have higher mortality, especially in newborn period, duct stent shortens hospital stay. Duct stent eliminates problems with the thoracotomy, reduces the number of operations, and optimizes the time of the surgery. We have been using duct stent implantation for the palliation of the cyanotic congenital heart disease for a long time, more than 15 years. We have started 2004, and this is a publication from my institution in 2007. And also, we suggested classification of the duct for cyanotic congenital heart disease, which is very different from Krechenko classification for simple PDA. And also, we showed the stenting of ductal arterioles in infant, which was in functional univentricular heart disease, which is a debate because of the pulmonary artery growth of the is very important in those patients who will undergo to Fontan tract. But we showed that it is very effective in these patients as well. These are the duct morphologies, how to approach the duct. This is a not interventional cardiology surgeon, so I don't want to speak about the technical details, but transvenous, transarterial, femoral artery, axillary artery, and carotid artery also are possible approaches. But in which patients we can do duct stenting in regarding to pulmonary artery morphology? Confluent pulmonary arteries without branch pulmonary artery stenosis are ideal candidates for this kind of treatment. Even non-confluent pulmonary arteries, confluent pulmonary arteries with branch stenosis, but not severe ones, are possible, and also for univentricular heart, which means functional single ventricle as well. And retrograde stenting in type A duct, which is the easiest one, and type B duct after crossing a coronary wire, they are usually straightened. And antegrade stenting in pulmonary with VSD, previously we used to do, but now, type D atypical duct needs at least telescopic method, at least 2 stents, because of the well-conforming the curve of the PDA, and both side approach for avoiding use long sheath. 2 different approach for bilateral duct and 2 stents for both pulmonary arteries. Nowadays, we prefer axillary artery or carotid artery approach. In this situation, we can also implant stent into the duct. Even if there is stenosis on the both sides, we can do ballooning for the both sides and then can be stented. What about left heart obstructive lesions in newborn due to insufficient systemic blood flow? Lesions needed treatment in newborns on the left side: critical aortic stenosis, critical aortic coarctation, interrupted aortic arch, hypoplastic or borderline left ventricle, or hypoplastic left heart syndrome. We can do aortic balloon, coarctation balloon, palliative coarctation stenting, duct stenting for systemic circulation, and left atrial decompressing procedure, such as balloon atrial septostomy, atrial septoplasty, and atrial septal stenting. I have already mentioned them. What about treatment options? In critical aortic stenosis, we prefer balloon valvuloplasty. We don't prefer surgical valvotomy. In critical coarctation, we prefer surgery first because of high recurrence rate in balloon angioplasty. Also, interrupted aortic arch, elective surgical correction, but in some situations, especially in patients with a complicated systemic disease, hybrid approach may be preferred. In hypoplastic or borderline left ventricle, biventricular repair is the goal. So in some situations, we prefer hybrid approach. Some institutions prefer direct stent to Norwood procedure. In hypoplastic left heart syndrome, instead of Norwood stage per surgical approach, hybrid approach can be performed at least in selected patients. In aortic valvular stenosis, usually we use retrograde femoral artery approach as a palliative balloon aortic valvuloplasty, and with a good result. But in some patients, associated abnormalities of aortic and mitral valves, aortic annular hypoplasia, mitral annular, or LV morphology, which is called as borderline left ventricle, the outcomes may not be satisfactory. and also intervention in the neonate due to intrinsic properties of the left ventricle and aortic valve, they have higher risks. When PDA closes, usually around 10 days, circulatory collapse may occur. Newborn should be stabilized with prostaglandin infusion and inotropic support before intervention. Unless the patient's situation is stabilized, the aortic balloon valvuloplasty shouldn't be done because it is possible. Aortic balloon has virtually replaced the need for open or closed surgical aortic valvotomy, which has higher mortalities up to 20%. It has similar or even better results when compared to surgical valvotomy in newborns. For this reason, it is the first choice of the treatment. While most retrograde femoral artery is used for aortic balloon, regular transcarotid axillary umbilical artery or antegrade transfemoral approach can also be used in this procedure. The goal of the aortic valvuloplasty is to effectively reduce the degree of stenosis as much as possible without creating significant aortic regurgitation. So always we start with a smaller balloon, then increase gradually. Most critical part is deciding for the size of the balloon. Shouldn't be exceed of the annulus size. This is a retrograde usual balloon valvuloplasty procedure. This is an antegrade aortic balloon valvuloplasty due to LV systolic dysfunction and the patient's conditions. The femoral artery pulses was absent, couldn't be punctured. First, transvenous approach, then after patient stabilized it, then we did retrograde balloon valvuloplasty in this particular patients. Any approach is almost always successful, but clinical response and hemodynamic improvement mainly depend on LV anatomy and functional integrity of the left ventricular. In some patients, that mitral valve annulus less than 8 mm and diastolic volume less than 20 ml per meter square, aortic valve annulus or less than 5 or no LV apex. Most centers prefer, it is a reasonable approach, univentricular repair as nerve stage 1 procedure as surgically. Some centers hybrid approach for delaying final decision. A few centers stimulating surgical strategies for stimulating biventricular repair. In coarctation aorta, the manifestation of coarctation are age-dependent. Neonates with coarctation may present with signs and symptoms of low cardiac output and shock once the ductus arteriosus closes. It is suspected when absence or weak femoral pulses suggested by the presence of a blood pressure gradient between upper and lower extremities. Transthoracic echocardiography confirms diagnosis, but it is not easy before PDA closes in some patients before 10 days of the life. So if suspected, repeated echocardiography should be performed in these patients. For native coarctation, initial surgical repair has been the primary treatment at most centers and remains the gold standard. However, balloon angioplasty in small children, as well as in newborn, in favorable morphology is effective, but in newborns, there are about 85 to 90% of recurrence after balloon angioplasty. So we don't prefer balloon angioplasty in a newborn unless recoarctation situation, even less than 3 months old. Coarctation appearing in the neonate are mostly complex, associated with arch abnormality, associated with, for example, large muscular VSDs. So, as a rule, a newborn with a coarctation we send to surgery. Exceptional indication for balloon angioplasty or stent implantation for bailout in newborn, poor clinical conditions due to sepsis or systemic disease, advanced left ventricular systolic dysfunction, high risk candidates for surgery, or very low birth weight, which is not appropriate for surgical correction. Or another our institutional approach. If there is associated with significant aortic stenosis, we prefer to do both in the same session in transcatheter, avoiding for open heart surgery in the newborn. This is an example with a necrosis and enterocolitis and relatively small baby with a LV systolic dysfunction, pulmonary hypertension, and sepsis. Favorable anatomy, no arch hypoplasia. We did balloon angioplasty, which was very effective. And you see the complete resolving of LV systolic dysfunction and coarctation after balloon angioplasty. And another patient, a coarctation is associated with significant valvular aortic stenosis, but lesion was treated in the cath lab. Hypoplastic left heart syndrome, it is characterized by hypoplastic left ventricle with atresia or critical stenosis of the aortic and or mitral valve and varying degrees of ascending aorta and aortic arch hypoplasia. There should be mandatory left to right shunt with an interatrial communication. It is present in almost all cases. Systemic circulation is dependent on right to left shunt through the atrial duct, aortic arch, and ascending aorta is also supplied retrogradely through the PDA. A conventional approach in hypoplastic left heart syndrome, no procedure at birth, superior cavo-pulmonary connection usually done at 4 to 6 months, and then Fontan completion as final palliation between 2 to 4 years old. Recently, the hybrid procedure has been proposed as an alternative to the initial nervous stage 1 procedure, which has higher mortality and long-lasting staying in hospital, especially in ICU. This procedure consists of bilateral pulmonary artery banding by the surgeon, and then duct stenting by the interventional cardiologist. If needed, left atrial decompression in follow-up by the interventional cardiologist. This is schematic illustration of the hybrid approach. You see the bilateral pulmonary branch banding and then duct stenting for systemic circulation. When we compared hybrid versus conventional procedure, some centers perform the hybrid procedure routinely as a first stage, Gissin approach or Columbus approach. Others prefer it in high-risk patients, especially in premature, low birth weight, or another systemic diseases. These advantages are the concerns about the pulmonary artery growth because of the bilateral pulmonary artery banding, the risk for retrograde coarctation from the stent of the duct, and increased interstage intervention rates. However, hybrid palliation in borderline left ventricle, it is a real alternative to stage 1 nerve procedure for delaying the decision patient in deciding whether the patient will go biventricular or univentricular repair.
Dr. Celebi, I'm so sorry to interrupt you. Sorry, but we can have only maximum of 5 minutes, if it's possible. Thank you. Sorry.
Yeah, it is possible because of, I have several slides, and then I will. Now, excuse me. In some patients also, after surgery, it is necessary to do transcatheter intervention for, in this particular patient, recanalization of the surgical shunt, sometimes completely occluded after surgical shunt in the ICU. And it is possible to balloon or stent. And also sometimes in some patients unable to wean from mechanical ventilation, in this particular patient, early surgical repair before duct constriction, it was overlooked due to early operation. Coarctation was treated by transcatheter intervention for avoiding the redo surgery and redo open heart surgery. In this particular patient, status post-truncus arteriosus repair, and left pulmonary artery stenosis very severe, and and was treated by stent implantation. And in the same patient also there was residual significant shunt through the VSD pitch, and then it was occupied by ADO2. And another patient, aortic stenosis became more prominent after the arch repair and arcus repair. It was treated by balloon valvuloplasty. And also in those patients, after Jatin operation, has difficulty in weaning from mechanic ventilation, MAPCA should be remembered and should be kept in mind. And MAPCA occlusion is very useful in this kind of patients to wean from mechanic ventilation. And rarely vascular communications such as pulmonary AV malformation in a 12 days old with significant hypoxia. It was closed by vascular plug in this particular patient. After vascular plug implantation, the hypoxia resolved. And so we have no time enough to talk about the PDA in preterm infants and transcatheter intervention in very low birth weight infants. So I'm gonna stop at this stage and go to my last slide, summary and conclusion. Symptomatic neonates with congenital heart disease mostly require emergent intervention, either surgical or transcatheter. Percutaneous interventions have important roles, not only single isolated simple lesions, but also in complex hyamotic congenital heart disease. Transcatheter intervention as a less invasive option are usually safer when compared to surgical palliation. They are technically demanding and requiring appropriate skills due to both the critical condition of the newborn and the characteristic of the interventions, and they are not without complications. So it should be performed by a well-experienced pediatric interventional cardiologist with a good pediatric cardiac team, including neonatologists, pediatric cardiac surgeons, pediatric cardiac intensivists, and anesthesiologists. Surgery, operating theater, and also ECMO should always be stepped by during the procedure. Thanks for your attention.
Thank you very much from Professor Celebi for your interesting session. Because we have a lack of time, I would like, if you can, you answer the questions in the chat for us, because they have some questions from you, because we want to go to Professor Borna. That thank you very much again for your attendance, and we hope to see you face to face in Istanbul or in Tehran as quickly as possible. Well, I would like to introduce our second speaker, Professor Reza Borna from UCLA of United States. I would like to apologize from Professor because of the we had to have one change in the program. Again, I would like to apologize from Professor Borna. I think that our audiences will be very excited because of his topic is thermoregulation in neonates. Well, Professor Borna, you welcome to our 32nd International Congress. We are very happy to have you over here, and we are all here for your interesting lecture. Thank you very much.
Sure. Thank you for having me here today. Yes, actually, I was here very early. This is very early in the morning here compared to your time in Tehran. So let's start. I'm going to share my screen. So, are we good? Okay, so today I'm talking about neonatal thermoregulation. Before starting that, we are all in the process of US election, but don't be distracted with losing this grand master of music and singing in our country. Why this topic is important, before I start my talk, I want to talk about this importance of the topic. Technically, hypothermia became something important, I would say 20, 30 years ago. And we start noticing the complications and the morbidity mortality that we see with the hypothermia in neonates and infants. That's one thing. And second, recently, I would say in the last 10, 20 years, we have more neonates, we have more premature babies. The birth of these babies are increased and we can save them. A lot of improvement in medicine have give us the opportunity to save these neonates. And then third is that we can use a very, very simple tools, very good education of our staff, which can improve the chance of this neonates to survive, just to avoid hypothermia. That's why the hypothermia itself become a center of attention to neonatologists, anesthesiologists, and everybody taking care of these babies. So let's start with some basic physiology first to understand what we are dealing with. When we are exposed to cold, there steps happen in our body. First thing is there are sensors in our body. We should detect this cold stimulus. And then we have pathways sending this message to the brain. And then after that, brain is going to act, and then it's going to send back this message to the body. And then we have some responses. So about the receptors, we have two types of receptors in our body, which is important for the thermoregulation. One is the one everybody knows about, which is the peripheral thermoreceptors. They're all over the skin. Every part of the skin, we have these peripheral thermoreceptors. And these receptors, when they're exposed to cold, they're going to send fibers of A delta to the center, to CNS. And when they're exposed to heat, they're going to send C fibers. And if you already know, the pain also is sent to the cortex by C fibers. That's why when you're exposed to heat, you might also feel a lot of pain, because it's the same fiber sending the message to the brain. So the messages all go to the hypothalamus, and the hypothalamus is the center that is going to make a lot of changes regarding this temperature change. On top of hypothalamus, we also send some fibers to the cortex. That's how we feel that we are cold. The body itself, through hypothalamus, is going to make some changes. On the other hand, we also feel that, hey, this is cold temperature or this is hot temperature. That's how you get up, you go close the door, you're going to change the room temperature, or you're going to get a blanket. That's the behavior attempts that you do to control the temperature change. So, and then we have a lot of central thermoreceptors. These are important. They are located in hypothalamus, in some other parts of brain, in spinal cord, and also in deep abdominal and thoracic tissues. In the past, we thought the peripheral receptors are the most important ones, but now we know it's almost 20% of our receptors are in hypothalamus, 20% in other part of brain, 20% cords, spinal cord, and then 20% in deep tissues. So these four combined include 80% of our receptors, and the other 20% goes to the skin. So as you see, the skin itself has only 20% of the receptors. So, and then it goes to hypothalamus. But hypothalamus is making a lot of decisions. It is going to make a lot of changes, and it's going to send to the organs to act towards the hypothermia. But hypothalamus is going to detect not the peripheral temperature. Hypothalamus is sensitive to core temperature. This is very important because when we are dealing with the very small babies and when we are dealing with hypothermia, when you're trying to manage this temperature problem, you cannot rely on checking the peripheral temperature. The simple things that, for example, we put something on the forehead, those are peripheral temperature, which can be affected by so many different things. We need to monitor the core temperature. But what is core temperature? The major site to control to measure core temperature is the pulmonary artery, but we don't have access to that. It's so deep, it's not easy to measure the temperature there. So we have some other options. This is important, which I always show to my fellows, that in this, let's say these four options, if you have, which one of them is not core temperature? Because we like in cardiac cases, We always like to measure we like to measure the temperature by bladder, but bladder is not a core temperature. The core temperatures are esophagus, the tympanic membrane, and nasopharynx. Tympanic membrane is not that easy to measure temperature with it. So the best one is esophagus. And when we go with a probe in mid-esophagus, which is close to, we can simply measure the pulmonary artery, close to pulmonary artery temperature, which is core temperature. So the response, first response, which is the easiest one, which does not have any ATP, any energy requirement, is peripheral vasoconstriction. That's the first thing. When the body does that, after that, if it's not enough, we go to sweating and then eventually shivering. These are the three major responses that we have. But on top of that, as I said, the signal is also sent to the cortex and we have some behavior changes. This is the most important part of changes. But the problem is, on neonates and on infants, we're missing this. So we do not have behavior regulation. So we have to count on the body control. So let's say with the babies, if we have the same three mechanism to control the temperature, the last one, which is shivering, does not work. They don't have muscles. The shivering is not developed in neonates and babies. Then we have something which is known as non-shivering thermogenesis. I'd like to talk about this for maybe a few slides because it's important in terms of the gestational age. So this is simply go through it. The whole thing is when we have hypothalamus activity, we're gonna have increased sympathetic tone. Because of that, we're gonna have no release. After that, we're gonna have active lipase, activation of the lipase. And then after that, we're gonna have increase in TSH, which is gonna do T4 and then T4 conversion to T3. And eventually, because of T3, we're gonna have uncoupling of a famous protein, which is thermogenin. Why thermogenin is important? Because thermogenin is responsible to cause or to create heat loss, to create heat at the level of the mitochondria. So we need to know what is this thermogenin because that's gonna affect our neonates. So let's go back to this non-shivering thermogenesis. It happens on brown adipose tissue. We all know about this. And this, technically, we just need 20 to 30 grams of this adipose tissue to have the non-shivering thermogenesis. And usually it starts at the age of 25 weeks gestation, but just keep this 25 in your mind right now. I'm gonna come back to it in the next slide. Usually this adipose tissue, this brown adipose tissue is around the kidneys and adrenal gland, mostly neck and some other area. The babies, they have this up to 3 months after birth. I always say 3, safer. Then after that, they're gonna lose this, so we have to use the other stuff to compensate for this non-shivering thermogenesis. The thermogenin that I was talking about, they start to develop secretion of this at the age of 25 weeks gestation, but it's not enough. The maximum and the best dose of the best concentration of thermogenin happens when they're 32 weeks. That's why the babies, the premature babies between age 25 and 32 weeks, they are very, very prone to hypothermia because they might have thermogenin, they might have non-shivering thermogenesis, but it's not enough. It's not appropriate. That's why they're very prone to hypothermia and the complications. But we should know what is normal. Of course, normal temperature is 37. And when we are talking about the temperature measurement in terms of normal and hypothermia, they measure axillary temperature. So 37 is normal, but we need a range. In the past, we always, especially WHO, is using the range of 36.5 at the lower level. But then after that, there's a very famous institution named the Acute Care of it's also called ACORD. In 2012, they started to saying that, no, let's bring the lower range to 36.3. So that's what we have right now. So based on this ACORD in 2012, if the normal is 36.3 to 37.2, then we have mild hypothermia, moderate hypothermia, and severe. But why the babies and the newborns, they're more prone to hypothermia? I can give you 4 reasons, and I'd like to emphasize on which one's the most important reasons why we have more hypothermia in neonates. They have higher surface area to mass ratio. This is something that we always should keep in mind, and that's how we should cover that. So why did I put this operating room here? First, because I'm working in operating room, and that's how we need to manage the temperature in neonates when they come to the operating room. But the other two other reasons that may be important for neonatologists. One is that you receive a lot of babies or even infants coming from OR to the neonatal ICU or to the pediatric ICU. So the temperature, how we are managing the temperature in the OR is important, and because you are receiving. Two is the environment of NICU and PICU is very close to the OR. So that's how is the similarity between these two locations can understand better this hypothermia. In operating room, we have two problems. Number one, anyway, because of the general anesthesia that we are giving to the babies, they have, and I'm going to show you why in the next slide. And second is the same thing with the labor and delivery room, the same thing with the ICU units, same thing with the operating room. The temperature, the room temperature is low in these locations. That's why the babies, when they're going in these locations, they are really prone to hypothermia. Actually, this is a nice slide I want to show you. The left picture is a normal person. As you see, the core temperature is 37. This person is feeling cold peripherally. And when it happens, the first thing, as I mentioned, is going to be vasoconstriction. And because of the vasoconstriction, this person is going to maintain the core temperature. But because of anesthesia on almost all of the anesthetics that we use, those anesthetics are going to cause peripheral vasodilation. And when that happens, the core part of the body has to distribute the heat to the peripheral. And just because of this, which is going to impair the thermoregulation, the core temperature drops easily. So that's how the anesthesia is affecting the temperature. This is very nice. As you see, when they come to the operating room, in the first hour, they have a significant drop in temperature. Then it's going to be slow in the second hour, and then after that, it's going to be steady and flat. So in the first 2.5 to 3 hours, drop the temperature by 3 degrees if you don't manage the temperature. But how the babies, they're gonna lose heat? They're the famous 4 mechanism of losing heat in babies. As we all know, conduction, convection, evaporation, and radiation. The reason I put this slide because I want to show you which one is more important. When the babies are born, maybe the number one reason for heat loss is evaporation because they have amniotic fluid cover them. They're wet, and when we dry them, and these things are going to start to evaporate, and they're going to lose heat. But after that, the major reasons when they are in an ICU or PICU, radiation and convection is the major mechanism of losing heat, and that's how we should focus to control temperature, and I'm going to show you with our tools. Do we get any benefit from hypothermia? These are known and they're not really proven, but we somehow know about this things. Number one is we have a protection mostly done in animals, not in human, but they say that by any drop in the temperature or 1 degree, we're gonna have 8% drop in metabolism, which is gonna help protect. These are studies in animals, but the point is this effect is going to get flat. So after 2 to 3 degrees, it's going to get flat. The other thing here in the US is we know this since maybe 10, 20 years ago is when we have cardiac arrest outside the hospital, if they can quickly make the patient cold, that's going to improve the outcome. And the other is when we have neonate with asphyxia, but these are really proved in our practice. So let's say when the babies in NICU, they become hypothermic, what happens to them? Of course, their extremities is going to become cold and they're going to have pale skin. That's maybe the first thing we're going to notice. Then when you check the glucose, they become hypoglycemic and bradycardic. And the one which is recently very important in our attention is that the shape of the breathing is going to change. they're going to start having shallow breathing, irregular breathing, they become restless. And if the neonatologist, they're not aware that this is a, or if they're not monitoring the temperature, just because of this tachypnea and irregular breathing, they think, oh, the baby is sedated, and they go and intubate the baby, but technically just warming the baby is going to fix everything. So as I said, respiratory distress, even apnea can happen if they become severely hypothermic. So any complication from hypothermia, besides the mortality that which I'm going to talk in next slides, but we have some famous complications. Number one is impaired coagulation. If they come with hypothermia, have a cold-induced defect in platelet function, and because of that, they are very prone to coagulopathy. After that, if they are having any surgery, these neonates going to have a surgery or having a surgery in the OR, they're going to have increased blood loss. That increased blood loss and the increased requirement of blood transfusions definitely proved. Of that, if they have any wound, they increase the chance of infection. And they say why we have increased chance of infection with this hypothermia. Number one, the immune function is not working very well. And second, because of this vasoconstriction that we have to prevent cold hypothermia, because of the vasoconstriction, the oxygen and the nutrition doesn't reach to the wound, and wound doesn't get better. Yeah, of course, as I said, the myocardial outcomes, any morbidity from the cardiac situation is going to weigh 3 times. And then if they are in recovery room or any reason, if they're in the hospital just because of hypothermia, they need to stay longer. And the last one is actually affecting us. But somehow it's also affecting the patient and the neonates. We use a lot of muscle relaxations and we use a lot of anesthetic. If the baby in the OR is receiving those medications, we have a drop in metabolism of those medications. So we give those medications, finish the surgery, we bring the baby to NIC or PICU, and they're going out and we leave. But the point is, if that baby is very cold, those medications, they don't metabolize very normally, and they're going to stay in the body. So the baby is still going to be paralyzed for 50% increase in paralysis just because of hypothermia. Or they're going to have a very, very deep anesthesia just because of hypothermia. So the baby is done with the surgery. You are waiting for the baby to wake up, but the baby doesn't wake up, or the baby doesn't breathe the way you like because the residual of this medication that we give in the OR. I try to actually change the studies that I usually show in my talk, and I use the studies mostly outside the US from other countries. So this is a very nice study. This was done in Ethiopia, but it was done by actually the physicians from New York, from US and Switzerland. They had a huge number of neonates, premature neonates. Technically, they have 3,852. And this is from hello? Yes, this is from the year 2016. I don't know what happened. From the year 2016 to 2018, and they have 3,852 premature neonates, and they checked the temperature. They found that hypothermia was associated with prenatal death, RDS, and resuscitation at birth, and definitely admission temperature. When the neonate is coming to NICU, the admission temperature is inversely associated with morbidity and mortality. This was also, I found this one a few weeks ago. This was also a study in Turkey, I guess, and they have this babies coming to the surgery being neonate or having a very low temperature in the OR or having general anesthesia. These are all the risk factors that's going to cause hypothermia when the baby is coming back to an NICU. But can we do anything, any changes which is going to help us to prevent hypothermia? That's the focus. That's the awareness that started 10 years ago. That said that, hey, look, with just simple things, we can fix this problem. We can drop the chance of morbidity and mortality with just some quality and improvement projects. So this study was done in South Korea, and they had a very easy project. And what they did was they add 3 tools to their babies, which was number 1 was using occlusive wraps. They wrap the babies. Second, they use warm blankets, and then finally they put a cap on the baby's head. And with just doing these 3 things, they have a very improvement in the temperature of the babies, and then also morbidity dropped. So as you see, the chance of hypothermia dropped from 71% to 45%, and the temperature increased from 35.4 to 35.9, just by doing these 3 things on the very low birth weight infants and neonates. The other study, this is done in Singapore, actually, if I'm not wrong. Yeah, this was done in Singapore. And what they did was they also did the same project, and they added, I'm sorry, let me go back. They added 3 things to the babies. And by using this measurement, they simply improved the temperature when the baby was coming to the NICU. So that's why starting 10 years ago, before 2012, technically, the WHO started to see that, hey, especially in underdeveloped and developed countries, we see that they somehow ignore this temperature. Second, they cannot control. That's why they had a severe increased chance of morbidity and mortality. So they start saying that, okay, when the baby first step on the delivery room, we need to focus, because that's the first part that these babies become prone to hypothermia. If they're after delivery room, if they come to the operating room, or if they come to NICU, it's very hard to bring the temperature up. So let's get from the first step, which is the delivery room. They offered 10 steps. They call that warm chain by WHO. So the first thing is increase the room temperature. Don't let the room temperature drop. So 25 degrees is hard to achieve, but that's the ideal room temperature for delivery room. Second, immediate drying of the baby. Third, skin-to-skin contact. Just get the baby next to the mom, let the baby be resting on the mom's chest. That's going to improve the temperature. Breastfeeding should start ASAP. And then if you're planning to weigh the baby or doing something which means detaching the mom or make the baby naked, because when you away with the baby, remove all the clothing, all the wraps, and you put the baby on the scale, and that's going to cause a significant drop in temperature. So postpone those. So use a lot of blanket and clothing, mother and newborn together. So they should stay together. If the baby does not have any medical problem, they should stay together. And then if you're transporting, that transportation is very important, because transportation from delivery room and ICU, from NICU to operating room, from operating room back to NICU, any of this transportation, if you're not equipped with good stuff, you're gonna be prone to hypothermia. And then the last one, which is if we do not raise the awareness in our staff in labor delivery, in NICU, in operating room, our residents, our fellows, if we do not raise the awareness, they just ignore those things, and this hypothermia develops and gonna cause all those morbidity and mortality. So what stuff do we have? I just want to finish this talk by the tools that we have to prevent hypothermia or to improve the temperature. The stuff that we are using right now in the operating room, the US, I'm going to bring these things. I'm not sure how many of these things we have in Europe right now, but these are the things that we are practicing, and we have studies here to prove that they're working. I just want to mention, first thing is, without anything, we need to improve the temperature. We need to increase the temperature. Technically, usually we have 23 degrees in the OR, which is very cold for babies. And ideally, we want to increase to 26 in operating room. That's the temperature that we are achieving usually in those small incubators when they come to the OR. But when we remove them from there and put it on the OR table, it's hard to temperature, but that's ideal. Pre-warming. Do not bring a neonate to an operating room cold. Let them become warm them enough, then bring them. Because as I said, correction of this hypothermia takes hours, and the surgery itself is just 2-3 hour surgery. So if they come to operating room, it's so hard for us to bring the temperature up. And if we bring them to you in neo ICU, it's so hard for you guys to increase the temperature. Warming blankets, radiant warmers, and blood warmers, and forced warm air devices. I'm going to talk about a few of these items, but first, I want to say which one is the best way, which one is the most effective way of controlling the temperature. The studies definitely prove the best one is forced warm air devices, and I'm going to show you. This was a study, actually, as I said, I was trying to remove all my US studies and put some international studies. So to see how we are doing these things in other countries. This is the study that I found in Germany, and they use this forced air warming system, and they saw significant improvement in temperature control. And this was for the baby infants in PICU and recovery room. So this is not a commercial slide. I'm not advertising about this device, but in the US, we call this bear hugger. And as you see, this is usually plastic wrap, plastic on top, and the bottom is something, I don't know exactly the quality, the material, but it's plastic wrap. And I see there are holes here, and you put this outside heat warmer. This heat warmer is going to create warm air, and the warm air is going to go in this area, and we're going to cover the patients, neonates, children, or even adults. So definitely that's the best way. And it's combination of, as I said, not one reason for losing heat. This is working with, and it's going to improve the temperature. In the past, we're still using these things in the operating room, but it's not practically that helpful. Why? Because the babies are naked maybe the 10-20 minutes of the surgery. Then after that, they're wrapped. When they're wrapped with the surgical drape, it's not working anymore. And the same thing we see when they come to ICU. Maybe they're going to work for a few hours, but they're not working for too many hours. And then on the other hand, it kind of causes complication. If you just ignore the distance between this radiance and the baby, you're going to cause burn. So we should be very careful with this. We use that right before the surgery and at the end of the surgery to increase the temperature, but not long enough. Warm blankets, we used to use them very often in the past, but now we are saying that this is not working. Technically, warm blankets is working if your baby is less than 10 kilograms. For those children, we can use them, but getting from them is not technically that much. So that's why that forced air comes to the picture better than this. The one that I'd like to show and talk about is the fluid and blood warmers. This is very important for us. We're using this very often, different devices, it doesn't matter, as I said, it's not commercial. So different devices that you put your fluids and your blood, if you're giving babies, and through that. And we were so happy that these are working very nicely because the temperature in the fluid warmer is very high. But the problem is that there are two problems here. Number one is that the IV that we are giving to adults, we can give 1 liter of the IV fluids in maybe half an hour. But in babies, we cannot give that high rate. That rate is very small, very low rate. And on the other hand, the distance from the fluid warmer to the baby is a long tubing because this is a very slow movement of the fluid through this. Even cold warm, by the time it reaches the baby's body, is cold already. So if you want to use this, you should become sure that your rate is a little bit increased, and then you need to become sure that the distance, at least the distance between the fluid warmer and the baby, use a very small extension, that the travel time is, for example, less than a few seconds, so it doesn't get warm. It doesn't get cold by the time it reaches the babies. So that's all I have for today. I hope I could cover as much as I was planned to, and I'm open to any question.
Thank you very much from you, Professor Borna, for your amazing conference. We really enjoyed it. If you let us, we have some practical questions from you that is very popular in our nice NICU. And at chat, most of my nursing staff and my residents are asking this. If it is possible, I would like in detail you answer. I will be very thankful for you. The first question is this: that when the baby is stained with meconium and it's a term baby, our nurses are a little bit fussy and they love to bath them as quickly as possible. I would like to know that when we have to bath a baby in the NICU when it is term baby, and what's the protocol for this? Then after you answer this, I go in the second part.
Okay. First part is usually, as you know better than me, those meconium, they're not happening mostly in term. Here we see most of those things in preterm babies. But for the term babies, if the baby is term and the baby does not come with any other medical problems, okay, technically they dry the baby. I mean, they get rid of those meconium when the baby is in delivery room, okay, but they don't bath the baby, and definitely they don't bath it there. And then when the baby comes to NICU, here we monitor the temperature for almost everybody. So everybody, we monitor the temperature. So they start thinking about bathing the baby if the temperature is good enough. If it's not, they just dry the baby. I know it looks dirty, it looks a little bit fussy, but we know dealing with that, even the smell is a little bit weird sometimes. Dealing with that is better than dealing with severe hypothermia. So we monitor the temperature. If the temperature is good enough, if we are not prone to severe hypothermia, not severe, if any degree of hypothermia, if it's not there, then we decide to bath. Otherwise, no, they just dry the baby. You're mute. You're mute. You're mute.
Yes. Excuse me. The second question is this: that when we have a preterm baby, well, this preterm baby, it stays a long time in the incubator until it be stabilized. One of the complaints what our nurses have is this: that, well, they say to us that, well, this baby is giving smell. And you know that, well, actually the women are very fussy to this kind of, they are very sensitive to these smells. They like to bath the baby. I would like to know that in your ward, what's a protocol you have, and when you have to bath these preterm babies, when they are stable, and in which weight you will bath him, and how will you bath him? This is one practical question that I'm seeing in the chat that they are all asking from you.
Honestly, I know somehow I know the answer, but not the details of the answer to this question. We don't bath. I know they don't. I mean, I don't know how to say it, but they don't take a shower with the baby. They don't put underwater. What they do is they use wipes. I don't know how they have it here over there. They just use wipes, and with the wipes, they just clean the baby. Definitely
with a tissue wipe, yeah, tissue wipe.
It's just a wet thing, but it's not wet like water. Is wet with some stuff that is on the tissue, and they just wipe the baby and cover the baby immediately. I know for preterm babies, they do not bath. The bathing, the regular bathing that you're expecting to have, they do not bath the premature babies. The term babies, they might if the temperature is okay, but for preterm babies, they do not bath. If they have problem with the smell, they're gonna just wipe it. But even for wipe, they're gonna wipe when they feel that the baby is stable. If the baby is not stable, they just wrap the baby, they put the cap on the head, and they just try to control the smell. I mean, because we know that, even as I said, weighing the baby, checking the weight of the baby, just very simple. It takes what? It takes 3 seconds. But for that, you need to remove all the blankets, all the wrapping stuff, all the cap, put the baby on the scale. With the scale itself is metal and it's very cold. Put the baby on the scale and check the weight of the baby. We don't do that. Technically, most of the incubators recently, they weigh the baby. You don't have to put on the scale. But even without those incubator, which is the fancy ones, we don't weigh the baby because we know just removing the blankets for 10 seconds is going to drop the temperature by 2 degrees.
So if we want to say at whole, in his Persian, we have to say, I think, dasmal khis, yes? Such a thing.
Because you said in Farsi, I said in Farsi. No, nah, that's malakhisnis. No, because that's malakhis in your term is wet with water.
No. This is one for wiping. It's a special kind of tissue.
Correct, but it's not water.
It's not water. Yes.
No, it's not hisnis.
All right. Thank you. Then another question is that well, we don't have that instrument for warming the blood, right? It's a problem what we have in our wards. I would like to know that if in case that we don't have such a instrument for warming the blood, what can we use in its substitution for?
Perfect. We had the same thing many years ago. Actually, what we used to do was this. So when the IV tubing is reaching the baby, at that part reaching the baby, we covered those with warm blankets. So we had very, very warm blankets coming, not attaching to the baby. Forget the baby. I'm talking about the IV tubing. The last portion of the IV tubing reaching the baby, we put them on the warm blanket, covered that with warm blanket. So whatever is coming, it's not effective like those instruments that I showed you, but at least the last second before reaching the baby, whatever is we are giving to the baby is going to be a little bit warmer before getting, because the blood transfusion, if you transfuse 10 to 20 ml per kg of cold blood, to the baby, that's going to drop your temperature very much. Just 10 to 20, because that's what we do, 10 to 20 ml per kg of blood, that's going to drop the temperature very significantly. That's why you need to use this instrument. And if not, that's what, as I said, use blankets, warm blankets. And you have to change these blankets every 20 minutes because they get cold. Okay, you get the warm blankets, you put the IV tubing, the last part of the IV tubing through these blankets, and it's going to go to the body at least.
Well, what with Paxil bags? How will you warm them if you don't have instruments? So under the warmer or in the, because we don't have these.
You don't have what? I'm sorry?
We don't have any instrument for warming the Paxils.
I know.
That's why.
I mean, the problem with PRVC, the Paxil, they come in the cooler. Okay, I think you have the same thing. They come in the cooler, and then technically we don't like to warm those bags because we think it's going to cause clotting of those things. So we don't like to warm them. That's why the only tool we use, and I've seen some of my fellows use some techniques to warm the bag, but we're asking them not to do that because that's going to cause coagulation. That's going to cause clotting of the blood, and we definitely don't recommend to warm the bag.
Well, thank you very much for your explanations and your patience, Professor Borna. We hope to see you one day or in America or in Tehran. Thank you very much.
Tehran, yeah, I miss Tehran. Okay, bye.
Bye. It's okay. Well, dear professors and my dear colleagues, the next session what we have is with Professor Goldsmith. I think it's a familiar name for everybody because especially the neonatologists in Iran, they have to pass his textbook. He's the author of textbook of assist ventilation. So all of the neonatologists, they are famous with Professor. Professor is working in Tulane University from New Orleans in the United States of America. Professor has a very humble character and he helped us a lot until we receive his file. You know, he sent us a file for 4 gig size, and that's a very big information for us. That's why it's nearly 150 minutes a lecture. So because we can't show all of these 150 minutes to you, we had to divide it to 2 files, nearly about 60 minutes for each. But surely we will put both of these 2 files on the YouTube that everybody can use. Professor, unfortunately, is not online. But again, I would like to appreciate him and thank him because of his cooperation, very, very close cooperation what we had. We had many emails with each other. Well, he has a very interesting session, and his session, it is respiratory management prevention in BPD. I would like that everybody listen and enjoy it. Thank you very much.
Hello, my name is Jay Goldsmith. and I'm Professor of Pediatrics and a neonatologist at Tulane University, New Orleans, Louisiana. Today's topic is respiratory management, the prevention of bronchopulmonary dysplasia. I have nothing to disclose, and I do not intend to discuss an unapproved or investigative use of commercial products or devices. At the end of this presentation, the participant will be able to identify 3 contributors to the cause of bronchopulmonary dysplasia in the premature infant, and name 2 evidence-based or best practice strategies to prevent BPD. Here we see a not uncommon picture of a physician trying to intubate an extremely low birth weight infant, either in the delivery room or in the neonatal intensive care unit. And it brings to mind the statement of Alan Jobe that there is nothing more dangerous to the preterm lung than an anxious physician with an endotracheal tube and a bag. So what is BPD? The clinical definition is oxygen or ventilatory support at 36 weeks post-menstrual age. But there's both a physiologic and functional definition to BPD. The anatomic findings are primarily in infants who have died and been autopsied. We see in new BPD a simplified lung, that is, arrest of normal lung development, with decreased alveolar septation and decreased and abnormal microvasculature in the lung. There's also inflammation as a biochemical association. In 2001, the National Institute of Health had a workshop and created these definitions of bronchopulmonary dysplasia, which are still used today. We divide the definition of BPD into 2 groups, one in babies less than 32 weeks gestation, and one in babies equal to or greater than 32 weeks gestation. In the less than 32-week gestation infants at 36 weeks post-menstrual age, we consider them to have mild bronchopulmonary dysplasia if they've been treated with oxygen for at least 28 days, but by 36 weeks of breathing room air, if they need oxygen at less than 30%, they're considered moderate, and needing greater than 30% oxygen or positive pressure ventilation, they're considered severe. If they're born greater or equal to 32 weeks gestation, at 56 days of age or approximately term, if they've been treated for more than 28 days with oxygen and breathing room air at the time of assessment, they're mild BPD. If they need less than 30% oxygen, they're considered moderate BPD, and needing 30% or greater than 30% or positive pressure ventilation, they're considered severe BPD. BPD is often contrasted as the old and new BPD. Old BPD was first described by William Northway in a seminal article in 1967 in the New England Journal of Medicine. He described our very early attempts to ventilate babies with mostly adult type ventilators that were slightly modified for neonates. We pounded these lungs pretty hard, and we got large cysts and areas of atelectasis with areas of cysts, so that these babies were larger and more mature than the babies who we see today with BPD. And they had severe airway injury, fibrosis, alveoli had developed in regions without fibrosis, but mainly this was caused by high oxygen use and very, very rough, high levels of ventilation. Today, the new BPD, which we see mostly in babies less than 1,500 grams or very low birth weight, airway injury is mild to none, fibrosis is minimal, but there's an arrested development of the lung. There's downregulation of new lung development. And so we have less lung over time in these babies who later develop into infants, and a tremendous interference with the development. So this X-ray shows old BPD, and hopefully you don't see many babies like this anymore, with this tremendous destruction of lung, alternating areas of cysts with areas of atelectasis, emphysema, depressed diaphragms, increased AP diameter of the chest, This is very bad BPD, which has a very bad prognosis. And these photomicrographs from Coulson in 2003 show a comparison of a normal term infant at 5 months of age with the normal structure of the lung. Here's a 28-week gestation baby who has new BPD with a simplified lung, not as many alveoli, some breakage of the alveolar structures, and abnormal microvasculature. This would be at the same 5 months post-menstrual age as this term infant at 5 months, and you can see the striking difference. Bronchopulmonary dysplasia is often described as a balance between pro-inflammatory factors that affect the newborn lung and anti-inflammatory factors, with BPD occurring because the pro-inflammatory factors win this fight. So we can divide this into 3 categories: hits to the fetal lung prior to birth, during transition in the delivery room and initiation of ventilation, and then postnatal hits. So in utero, a baby whose mother has chorioamnionitis will have inflammatory cytokines and chemokines, which will affect the fetal lung. And then during birth, initiation of ventilation, especially if it's too vigorous, and ventilatory support will affect the preterm lung, as well as how much oxygen is given and whether the baby develops sepsis. And this all may end up developing BPD. On the other hand, corticosteroids given to the mother prior to birth seems protective of the fetal lung, although it's difficult to prove this statistically. Surfactant seems to protect the lung from high ventilatory pressures. Again, hard to prove statistically. And then corticosteroids given after birth to the preterm baby seems protective of the lung, although there are side effects to those corticosteroids and we hesitate to use them. Also, good nutrition here seems to help as an anti-inflammatory process to protect the preterm lung. The adults call injury to the lung induced by the ventilator as VILI, ventilatory induced lung injury. We have the same process with the fetal lung. And the question is, what causes it and can it be prevented? And are we, as caretakers, physicians, nurses, RTs, at least partly responsible? Dr. Marty Kessler has called this physician-induced lung injury, or PILI rather than VILI, since he feels that the way we operate the ventilator has a great deal to do with the development of ventilator-induced lung injury. There are 4 major traumas to the lung that can occur during the neonatal period, mostly to prematures. These 4 traumas are barotrauma, or striking the lung with a ventilatory pressure, volutrauma, or overexpanding the lung, stretching the alveoli, biotrauma, which is infection, and atelectotrauma, allowing the lung to become atelectatic and unexpanded or collapse, and then having to re-expand it, such as what would happen, for example, after an accidental extubation, or when we don't inflate the lung well at birth and don't establish a functional residual capacity. It has been shown in animal models that 5 minutes of assisted ventilation, especially aggressive assisted ventilation, can produce lung injury. And that overdistension, volutrauma, overdistending the individual alveoli and literally tearing the tissue, is probably the most common cause of lung injury. Here is a diagram that Alan Jobe and Ikigami did several years ago, showing exactly what our problem is in terms of ventilating the premature lung. This is a pressure volume curve with pressure on the x-axis, volume on the y-axis. And we see here a low volume zone where lungs are allowed to become atelectatic. That's potentially causing injury. And then a high volume zone where we overdistend the lung and cause volutrauma. We also see down here in lung volumes what the difference is between adults, a term newborn, and a premature. And we see here how narrow this sweet spot is of tidal volume. Once we expand the functional residual capacity, we have to hit this very, very small tidal volume in order to avoid the injury zones above and below that sweet spot. Back in 1987, Mel Avery, then working with the NICHD 8 centers, asked them to look at their BPD and survival rates and compared them in a classic paper. And here you see the 8 different centers. Their survivals were pretty close to each other, but notice in red here the difference between their BPD rates. These are all babies less than 1,500 grams, where we have BPD rates up to 40% in center 5, and center 3 is down here at about 10%. And everybody said, well, who's center 3? And that was Columbia. And everyone since that time has tried to mimic the way Columbia and Jen Wang and others, Rich Poland and others, have ventilated their babies in order to achieve a lower BPD rate. This was again amplified by Linda Van Marter in 2000 in Pediatrics, where she compared the practices and outcomes of Babies Hospital at Columbia versus 2 Boston hospitals. And she looked at mechanical ventilation in the 2 hospitals, Babies here in blue, Boston in red. And you can see that mechanical ventilation is much greater at Boston, and CPAP, nasal CPAP, much greater at Columbia. The use of surfactant, much less in Babies Hospital, Columbia. And notice the BPD rates, 22% in Boston, and I think at that time 6% in Babies Hospital for babies under 1,500 grams. This was a very instructive paper, and the good news about it is Dr. Van Marter didn't lose her job since she was publishing from Boston, and generally they don't want to hear that someone else is doing a better job. But it helped, I think, move the needle a little bit away from automatic intubation, ventilation, and surfactant in babies under 1,500 grams. Here's the Vermont Oxford data from 2005 and 2014, looking at the percentiles of mortality, chronic lung disease, late onset infection, neck, intraventricular hemorrhage, and retinopathy of prematurity. You notice that through the years, from 2005 to 2014, there's been a nice drop in mortality, certainly a big drop in retinopathy of prematurity and late onset infection, but that basically chronic lung disease, which started here at 30% in 2005, is mainly about 28% in 2014. Not a big difference. It's been a very difficult problem to reduce the incidence of BPD. This quality improvement programs and lots of attention to this problem. And Dr. Stoll, Barbara Stoll, in JAMA 2015 looked at the Neonatal Research Network Centers, the NICHD centers, and actually showed from 1993 to 2011 an increase in bronchopulmonary dysplasia in these very small infants from around 35 to above 40% at the time that she looked. Now, this is not an easy problem to solve. When we look individually at weeks of gestation, and this again is Dr. Stoll's data, at 22 to 28 weeks, looking at almost 7,000 babies. At 28 weeks, an incidence of 24%, and we get down to 23 and 22 weeks, we can see how high the incidence of BPD is based on the NIH definitions. And taking this entire group, and remember this is a group of babies quite small, 28 weeks or about 1,000 grams, and down to all the way down to 400 grams, we see an incidence of 45%. However, it depends on how you define BPD, even if you use the NIH definitions. So if you don't want to be in oxygen at 36 weeks or 56 days after, if you're born greater than 32 weeks, you can manipulate the oxygen use, and there are different ways to do that. You can accept lower saturations, as Dr. Walsh showed in this paper in 2004, accepting saturations in various centers down to 88% rather than in the 90s percentile. Or you can use pressure such as high flow without oxygen, or you can use diuretics or steroids. And then a factor on the other side, making your BPD worse, is that if you're at higher elevations, especially at 5,000 feet or above. So here we looked at 17 centers, or Dr. Walsh looked at 17 centers, and you can see the black is the clinical definition of BPD based on needing to keep the saturations greater than 90. And here in the open bars, you can see the situation that if they accept down to 88% saturations, there's some remarkable drops in the incidence of BPD. Dr. Alan Spitzer talked about BPD in terms of the 7 Ps: prematurity, positive pressure ventilation, prolonged oxygen exposure, prolonged airway trauma, pulmonary edema, perinatal exposure to infection, and poor nutrition. All of these appear to be factors which increase the incidence of this chronic lung disease. So in order to decrease BPD, we have to think of it as being a multifactorial problem with many different approaches. And a number of different approaches have been tried in quality improvement projects and other groups through the Vermont Oxford and the Neonatal Research Network in order to decrease the incidence. First of all, if you decrease the incidence of very low birth weight and extremely low birth weight infants, you can probably reduce the incidence of BPD. Having mothers get steroids prior to delivery of their babies is very helpful, although in large studies, it has not statistically been proven to decrease BPD. Other ways of approaching this, which we'll discuss later in this lecture, are the golden hour care, trying to make sure that first hour of life is scripted and very carefully done, the potential early use of surfactant, or certainly developing a functional residual capacity in the delivery room by early use of CPAP. Avoiding intubation, increase CPAP use and success, especially starting early in the delivery room. Use low tidal volume ventilation, decrease volume barotrauma, prevent accidental extubations, provide adequate nutrition, fluids, and oxygen management, give vitamin A and caffeine, and prevent infection. These are all strategies to decrease BPD. So some of them have been proven in large studies, others not. But for example, antenatal steroids have been noted when given to the mother for 48 hours to decrease respiratory distress syndrome, but not bronchopulmonary dysplasia. Surfactant, which we would expect would have a wonderful effect on decreasing BPD, but randomized controlled trials have failed to show a decreased incidence of bronchopulmonary dysplasia. This is offset by more extremely low birth weight infants surviving, and maybe can be offset by less invasive methods of giving surfactant, which we'll talk about later. Using CPAP in the delivery room to develop a functional residual capacity, using non-invasive ventilation and avoiding intubation, having mechanical ventilation strategies, including volume targets, using gentle ventilation with acceptance of hypercapnia, using such techniques as NAVA, neurally adjusted ventilatory assistance, and other approaches. Oxygen targeting, keeping your oxygens in a targeted range without allowing babies to get hyperoxic or hypoxic, using vitamin A injections, caffeine to enhance early extubation and management of the patent ductus arteriosus. Some of these strategies have been proven in randomized controlled trials. Delivery room CPAP, caffeine, vitamin A, postnatal steroids, and volume targeted ventilation all have been shown to improve the incidence of BPD. Vitamin A is not used as much as possibly it could be because of the number of injections it requires. Postnatal steroids may cause other problems, and people are reluctant to use them unless they're absolutely needed on a baby who's been ventilated for a prolonged period of time. Other approaches to decreasing BPD have equivocal evidence from clinical trials, including antenatal steroids, surfactants, early ductal closure, high-frequency ventilation instead of conventional ventilation, non-invasive ventilatory support, in other words, not using an endotracheal tube, inhaled nitric oxide, and reduced oxygen exposure. So, how do we minimize lung injury? Certainly, oxygen saturation targeting has been one approach that has been looked at, and it's very difficult to get statistics that will support that this makes a difference in a large population, but certainly other aspects of hyperoxia and hypoxia make it imperative that we do targeting in our units. Initial stabilization of the baby in the delivery room with development of a functional residual capacity by using CPAP. And then in those babies, especially where mothers have not received surfactant, where there's evidence, where the mothers have not received betamethasone, where there's evidence of infection, or where there's evidence of hypoxia, significant hypoxia, which may decrease the production of surfactant by the type 2 cell in the endogenous fetal lung, those babies may benefit from early surfactant treatment. Then once the baby is in the unit, the use of gentle mechanical ventilation, prompt extubation when the baby is ready, and non-invasive ventilation if we can avoid an endotracheal tube. So the question is, does early CPAP in the delivery room reduce the need for intubation and ventilation? There are multiple randomized trials of delivery room CPAP versus standard care. The three big trials are the COIN trial from Australia, CPAP or intubation, the support trial from the United States, and the VAUGHN trial, which is known as the delivery room management trial, which we'll talk about. And then the surfactant options are giving surfactant prophylactically within 15 or 20 minutes of birth, or to do an insure approach, intubate, surfactant, extubation, or wait until the baby declares himself or herself as having true respiratory distress syndrome and then using rescue surfactant. So delivery room interventions has been the subject of much discussion and research, and whether or not it can prevent BPD. People have looked at whether CPAP versus mechanical ventilation is better, or whether you should have a sustained inflation initially to open up the lung, since the lung is collapsed at birth and we're trying to develop a functional residual capacity, versus just standard intermittent positive pressure ventilation. How much oxygen should we give during resuscitation? Should we give early surfactant and extubate like an insure approach, or use nasal CPAP? If we're going to do surfactant, should it be early, less than 2 hours, or late? Are there methods to give surfactant other than through an endotracheal tube? And these are being looked at now, called less invasive surfactant administration, or LISA, and then the golden hour protocol. So here are the three major studies looking at CPAP versus standard care in the delivery room. The COIN trial, which looked at 25 to almost 29-week babies, support 24 to 27 and 6, and the Vermont Oxford, which looked at 26 to 29, 6 babies. You can see a large number of babies enrolled, over 2,500. The comparison of CPAP to intubation support was CPAP versus intubation and surfactant. In the VAUGHN study, which was 3 arms, one was CPAP, bubble CPAP. The second was prophylactic surfactant and mechanical ventilation. And the third arm was the insure approach, intubation, surfactant, and extubation. When we look at the outcomes and we throw in 2 other smaller studies from outside the United States, we can see that there's really no statistical advantage to CPAP in either BPD or death. The risk ratios here with a 95% confidence intervals all cross 1, and none of them give a significant advantage to either early CPAP or early intubation and surfactant. The one thing that did stand out in the Australian trial, the COIN trial, CPAP or intubation, is that when they put the babies on CPAP, and the theory is that they got more atelectasis and then had to re-intubate or had to intubate some of them later, they had a much higher pneumothorax or air leak rate, 3 times as high. That was not borne out in any of the other studies. So these studies, which have been going on for over 10 years now, have not informed us of what approach to take. And here, if we look at the Cochrane database, we can see in looking at these major trials that there is a slight advantage. This is the CPAP side of this forest plot, and this is the standard ventilation approach. And there is a slight, very small number of advantage. And this is published, Cochrane database 2016. The evidence from these 3 large trials looking at 2,358 babies, primary CPAP therapy compared with mechanical ventilation reduced the risk of BPD or death with a small advantage. The confidence interval was 0.81 to 0.97, and the number needed to treat was quite large, 20. So yes, there was a small effect of CPAP compared with mechanical ventilation if you could avoid mechanical ventilation totally. So this leads us into the concept of, can we provide ventilation through non-invasive respiratory support? And this is becoming very popular around the country, either through nasal cannula, high flow nasal cannula, CPAP, continuous negative expiratory pressure, which is hardly used, but also nasal ventilation in various forms. In an effort to avoid an endotracheal tube, there have been a couple of studies that have looked at this, mostly done in smaller numbers, but when you put them all together, 7 trials, which were reviewed by Fisher and Bureau in 2013 in Pediatrics, showed a small but statistically significant reduction in BPD or death in those babies who had non-invasive ventilation versus those babies who were intubated and had standard mechanical ventilation and surfactant. The odds ratio was 0.83 with a confidence interval, again, pretty close to 1, but below 1, so there's a small advantage, 0.71 to 0.96. So the question is, why is an endotracheal tube bad? And you can sit and think about this for a while, but it allows large tidal volumes, volume trauma, which we know is one of the traumas of BPD, high peak inflating pressures, especially when it's unregulated, like when we're doing bag to tube ventilation. Ventilator-associated pneumonia or biotrauma is also more common when there's an endotracheal tube in place. The tube is easily plugged or partially obstructed, leading to increased resistance and decreased tidal volume, which leads to atelectotrauma. So those are our 4 traumas that we know cause BPD. Endotracheal tubes also lead to subglottic stenosis, vocal cord, palatal, and tooth damage. There's ciliary damage and prevents the natural pulmonary toilet of the trachea. And then we have unplanned extubation, since all of our babies are ventilated through uncuffed tubes. When a baby extubates, you get atelectasis, possibly a difficult reintubation at a difficult time, usually in the middle of the night when you don't have your first team there, and things.
Well, dear audiences, this is the first part of Professor Goldsmith's speech. That's why the second part, because it's very big, as the data is nearly 2 gig size. That's why we can't show it for you. We will try to put this link on the YouTube, and you can watch the rest on the YouTube. Thank you very much for your attendance.
And don't forget to follow us We'll have the ICU session after this in 15 minutes.